Kashyap, you can rename.
Karthik, can you just call this Raymond guy and tell him I'll call back later? He's calling again. I'll send you the number.
So we will be starting now. Good evening, everyone. So welcome back once again. On behalf of IAP Allergy and Applied Immunology chapter, myself, Dr. Neeraj Gupta, would like to welcome all of you and would like to thank all of you for attending this very important webinar series. As you are aware that we have started this webinar series from 1st of August, in which we have already discussed about certain basics of allergen immunotherapy. We have already talked about that how this allergen immunotherapy evolved over some time. And then thereafter, what is the immunological mechanism, how it is rewiring the immune system, which we have discussed, and then who should be given allergen immunotherapy and when it should be selected. Now today, in sequence to that, today is a very important day in which we will be discussing about role of various investigations, whether it is in vitro testing or in vivo testing, during allergen immunotherapy, selection of allergen immunotherapy and monitoring of allergen immunotherapy. And simultaneously, we will also be discussing that, okay, which particular modality of immunotherapy should be started and how on which particular parameters should be used to select a particular allergen or a particular modality. So this is a very important day for us today. And I would like to welcome Dr. Hema Matthews. She is a very senior pediatrician and pediatric allergist from Kochi, and she is working in a tertiary center called Lisi Hospital. So she is a very renowned allergy specialist, pediatric allergy specialist from Kochi. I am very fortunate that Dr. Hema Matthews has accepted our invitation. So thank you very much, Dr. Matthews. You can please start now.
Thank you, Dr. Neeraj. First of all, let me thank you for the opportunity. And Dr. Neeraj, he's my teacher and he's a great inspiration for all of us. And we have seen that in the last few months, the allergy chapter of our IAP is going through groundbreaking innovations. So let me thank you first for taking so much effort for this allergy in spite of your busy schedule. And as Dr. Neeraj has already mentioned, so this is the second session of our allergy immunotherapy series. And today, the first talk will be on, we all know that the success of allergen immunotherapy that depends upon how you interpret the skin prick test and the specific IgE test. So for that, today we have one of the eminent allergists from Chennai, that is Dr. Kashyap Nagaraju, and she is a renowned ENT specialist as well as allergist, and she's a great practitioner. More than that, she's one of the coordinators of fellowship in Savita University, and she's a great research person also. So let us hear from Dr. Kashyap. Over to you, Dr. Kashyap.
Thank you. Thank you so much, Dr. Hema ma'am, for the nice words. Thank you, Dr. Neeraj sir, for the wonderful opportunity. I'll straight away jump into the session for today. Let me share my screen. I hope the screen is visible and the slides are moving.
Yes, your slides are good. You can please start.
Okay. All right. Good evening, one and all. Today, we will be discussing about interpreting skin prick test and specific IgE for the success of allergen immunotherapy. I'm sure last Friday's session was excellent in touching upon the basics of it. But what is immunotherapy? Allergen immunotherapy is basically the only disease-modifying therapy available for the notorious epidemic that we call as allergy. And what does it generally deal with? Allergen immunotherapy, as we all know, deals with serially given allergen extract for the patient suffering from the allergies to increase the tolerance of the specific allergen and also to bring a shift from Th2 to Th1 response. But this actually generally takes a lot of time. Approximately 3 years is what the guidelines would say. So for this, what we need to do is find out the appropriate diagnosis, the first step in achieving allergen-specific immunotherapy, in prescribing allergen-specific immunotherapy, is setting up an appropriate diagnosis. In today's talk, we will be dealing about the understanding the role of skin prick test and specific IgE interpretation apart from the diagnosis of that particular patient. And we'll also learn how to identify clinically relevant allergens, predict the responders per immunotherapy based on these tests, and also to avoid either under or over treatment for the patient. We'll also discuss about some clinical scenarios in real world where allergen immunotherapy outcomes will be based on skin prick test and specific IgE. So why does interpretation of allergen-specific immunotherapy matters? We all know that allergen-specific immunotherapy is effective, but not all patients respond equally. So even though the patients present with similar conditions, and we give standardized immunotherapy, the effectiveness which is seen generally differs from person to person. So tailor-made immunotherapies are actually needed in the current era to achieve the maximum effectiveness of allergen-specific immunotherapy. The success of which generally depends upon the selection of the appropriate patient for the appropriate therapy to correct the allergen targeting and interpretation, which is both meaningful and timely. So once the tests are done, it has to be interpreted with a clinical correlation. Any misinterpretation generally leads to a wasted effort and wasted time and money for that matter. So we all know that the success of allergen immunotherapy is a slow process, but the success does not directly imply the control of the symptoms. Success is also measured for allergen immunotherapy with disease control, with prevention of sensitization, and also disease remission. The disease control with respect to allergen immunotherapy is measured in severity of the symptoms, duration of the symptoms, assessing how many exacerbation rates the patient has overcome and how the rates have come down, and the less number of the hospitalizations, and overall improving the quality of life of the patient. Prevention of sensitization, neosensitization can be prevented by allergen immunotherapy. All of us know that. So the success of immunotherapy also depends on this. And progression of sensitization to clinical reactivity can also be assessed. The disease modification or remission process is where we are halting the symptoms of the patient to a particular section. That is, if the patient is having severe allergic rhinitis, we try to halt that atopic march, not going into a severe asthma. So we try to prevent asthma prevention, we try to also make it a cost-effective scenario. So all these together lay the foundations for allergen-specific immunotherapy. We know that sensitization is definitely not equal to allergy. So just being sensitized is not enough to choose an allergen-specific immunotherapy. What exactly is important in making a clear-cut diagnosis or even choosing immunotherapy? The first and foremost step definitely lies in appropriate medical history and the physical examination, following which there are other steps which include the in vivo, in vitro diagnosis, and the gold standard is always a organ provocation test. Let's talk about SPT and specific IgE. These are not necessarily, the sensitization does not correlate with a clinical disease per se. Always put it together with the history, and this will help in interpretation. If we rely more on the tests without the context of the history of clinical correlation, we always will have poor outcomes with respect to allergen immunotherapy. There is a triad of success in allergen immunotherapy, which is consistent clinical history, a positive test, relevant clinical exposure for the patients for which the particular antigens have been selected for immunotherapy. These three together form the triad of success for allergen-specific immunotherapy. Let's start with skin prick testing. We know that it's a gold standard test for demonstrating the specific IgE, which are bound to the cutaneous mast cells. So everyone must be aware of the technique per se. We take a small amount of allergens, place it over the forearm or the back, make a prick, wait for 15 to 20 minutes. And the allergens tested generally depend on the history of the patient gives regarding their allergies. The wait period generally is for 15 to 20 minutes, following which we do grade the symptoms, 0 being the lowest and 4 being the highest. There is a rule that the mean wheel diameter should always be greater than 3 millimeters of the negative control, that is saline. That is taken to be a positive skin prick testing, which is actually influenced by a lot of factors. The skin prick test as such, the first factor being the clinical history and plan for relevant allergens. So you cannot choose random allergens to test in skin prick testing, which are not correlating with the clinical history. For example, testing a panel of non-vegetarian foods for a patient who is a strict vegan or a vegetarian, who has never consumed non-vegetarian food in their life. So availability of skin for testing of skin prick testing, especially in atopic dermatitis patients where the skin is extremely frail, you will not be able to perform it. And technical issues, there is interprick variability, experience of the performer matters a lot, and allergen standardization is one of the major factors which does influence the skin prick testing. There are other multiple factors which do influence, but these are the major ones. So interpreting of SPT is very, very important, wherein the wheel size generally correlates with the likelihood of allergy. So the size of the wheel does say that the patient may be sensitive to that particular allergen, but it is not alone the indication for choosing a allergen-specific immunotherapy. The quantitative wheel size is not the predictive for the severity of allergy as such. So this is a study which was done in Europe, wherein they have checked based on the specific IgE, the sensitivity of and specificity of specific IgE. You see here that the skin prick test wheel flare diameter is 6 millimeter for house dust mites. The specificity is approximately almost 100. This was made based on the nasal provocation. The same patient who was undergoing a specific skin prick testing was made to undergo a nasal provocation test as well. So here, what I mean to say in this particular slide is that there is no absolute cutoff for a specific allergen in skin prick testing. That is, here we see that house dust mite might require 3 millimeters to be positive. Grass mix may also require 3 millimeters according to this particular study, whereas the dog dander and the cat dander are quite high in their size, in the wheel diameter. So basically the allergen type matters the most. So the way in which you interpret skin prick test for allergen immunotherapy is always the clinical correlation along with, say, for example, you have a patient who has both house dust mite and mold sensitivity. We always choose house dust mite compared to the mold because the data for immunotherapy in house dust mite is much higher compared to the success rate of house dust mite is more compared to mold. So the potency of the particular antigen is also to be considered in this specific thing. So moving on to the specific IgE testing, as we all know, it's a blood-based testing to identify the circulating specific IgE levels, which can include almost 200 to 300 different antigens can be tested, which is very highly sensitive method of testing for specific IgEs. The interpretation again is either qualitative, quantitative, or semi-quantitative. Quantitative being the most reliable. FADIA is, Immunocap is the most quantitative technique that is available. So as I said, quantitative is preferable. There is no, again, absolute cutoff for specific IgE based on which we can choose the allergen-specific immunotherapy. It's just that the higher the levels of specific IgE, it is generally indicating that the clinical relevance is quite high. In the same study that we discussed earlier, we also see that the patient was made to undergo a specific IgE for house dust mite, which turned out to be 17. The specificity here has decreased to 98. So that just means that it is only giving a clinical relevance rather than the specificity is not as high as in comparison to specific IgE. We should also consider lately we have a lot of physicians or a lot of allergists practicing this step wherein specific IgE to total IgE ratios are generally predicted. It may require more data. The reason being that both the tests are generally done in different methods. The measurement of them is also mentioned in different units. So that is why, even though it may be a reliable tool, we do require more data regarding this. So greater than 3.5 KUA per liter, this is something which we have seen multiple physicians trying to start immunotherapy based on this particular value. But this may not be holding good for each and every group of allergen, because as you see in this particular study, the value for house dust mite is 9.5, whereas specific grass has 8.4. So the value doesn't matter with regards to specific IgE. Please do not choose specific IgE based on the values alone. So concordance of specific IgE versus SPT, what we generally see is that if both specific IgE and SPT are positive, there is a clinically relevant sensitization which is happening. If SPT is positive and specific IgE is negative, there is a borderline sensitization. We should definitely look into a possibility of local IgEs that are circulating. If a specific IgE is negative and if a specific IgE is positive and SPT is negative, there is still a early or a low level of sensitization. But if both are negative, that is when allergen immunotherapy is not indicated unless the patient has been made to undergo a provocation testing, and that is positive. So concordant results as such increase the confidence for taking the decision of immunotherapy. But when both of them are available, use the clinical history as the tiebreaker in such scenarios. Also remember that in many scenarios, both skin prick test and specific IgE may be required in getting to a conclusion for deciding the immunotherapy. The best is history along with both the positive tests. So there are certain responders which will help in predicting certain points which will help in predicting the allergen immunotherapy response. The best responders generally are monosensitized patients with high specific IgE, which larger SPT, which house dust mite and grass allergy having the very best response. Whereas poor responders for allergen immunotherapy are generally polysensitized patients where there is mismatch between the symptoms and the test that the patient has undergone, and the patient has a very poor adherence to the allergen immunotherapy. So what should not be done is start allergen-specific immunotherapy based solely on the positivity of a particular test. And what should also not be done is targeting allergens to be tested that are not clinically relevant, that are poor quality allergens, and also do not ignore the discordance without investigating further. Like, for example, if both are positive and you're not able to come to a diagnosis, if there is a suspicion of a cross-reactivity, you will have to consider a next further step, which is called component resolved diagnosis, which will be dealt by the next speaker. So many people, especially patients, do tend to ask, once we start an allergen immunotherapy, they do tend to ask if they can measure the success of immunotherapy or monitor the success of immunotherapy by repeating the tests. In this scenario, SPT and specific IgE. Generally, it is not recommended to repeat for routine monitoring purposes, but we do consider this wherein we see that there is a decline in specific IgE. Generally, what happens is this graph shows that there is a relative increase in the levels of specific IgE as soon as we start the immunotherapy, which keeps on going down as the immunotherapy progresses. As early as 1 to 2 years is what is generally required for the actual specific IgE to come down. The skin prick test wheel may or may not come down even after starting of immunotherapy. So generally, it is not recommended for a routine monitoring. But what are more useful for monitoring the response of immunotherapy are the symptom or medication scores, the patient satisfaction as such, and how the overall day-to-day activity of the child has improved. So we have a case here wherein we have a 15-year-old male with allergic allergic rhinorrhea and allergic symptoms, rhinorrhea, sneezing, nose block, and everything, which is perennial in nature. wherein the symptoms are more worse at night and indoor generally with the basic common triggers. So this skin prick test was suggestive of house dust mite positivity with Burmata grass positivity as well. Specific IgE also showed 12 KUA per liter for house dust mite and 0.8 for Burmata grass. We have offered the patient house dust mite immunotherapy, and the patient is doing well. Why was Burmata grass not selected in this patient? As simple as that, it is not clinically relevant to the patient. He was monosensitized, he was having perennial symptoms, he's doing excellent with the single therapy. Not as in this case, wherein we have a 10-year-old boy who resides in Europe who has allergic rhinitis, allergic conjunctivitis, atopic march, the typical atopic march that you actually see. With new onset of breathlessness, wherein the symptoms are indoor, perennial, and also worsen while playing in open field. The patient also has a positivity, positive specificity to cat as such, which the exposure is at the friend's house. The skin prick test showed positive for HDM, the dust mites, pollen, and cat dander. What is the immunotherapy that we generally choose in this patient? Here, the choice of immunotherapy choice of allergen for the immunotherapy is purely clinical. We do not treat the SPT or the specific IgE only. So in this patient, my initial choice would be a house dust mite immunotherapy. Start him on a proper house dust mite immunotherapy. Follow it up until 6 months of duration. See if he is having any betterment of symptoms. In case he has any worsening of symptoms during the pollen exacerbation, I would still wait and think over adding on a pollen immunotherapy for this patient. We generally follow this algorithm at our place, wherein tend to see the causative allergen for different clinical presentations in different seasons. For example, we have rhinitis and rhinoconjunctivitis, which is generally seasonal symptoms. We suspect pollen. Whereas the same added on with asthma, which is perennial symptoms, the most probable diagnosis, suspected allergen is house dust mite. Whereas the same symptoms along with the add-on nasal block and chronic rhinosinusitis, we suspect, which is seasonal and perennial in nature, we suspect a mold infestation as such. Let's conclude. I would like to conclude my topic for today by insisting on these points that interpreting the skin prick test and specific IgE wisely improves the allergen immunotherapy success. The concordance with clinical history is always essential. Please avoid a test positive and treat the positive mindset. And right patient, right allergen, and right method are the triads for the allergen immunotherapy success. Thank you so much.
Thank you, Dr. Kashyapi. So you have very beautifully narrated regarding the interpretation of SPT and the specific IgE. And more than that, what not to be done. You have very specifically stressed on that. And the clinical identification of allergens. We always say the clinical history is the most important one. And that was an excellent slide. So thank you, Dr. Kashyapi. So I think we will move to the next talk of today's series. And polysensitization is actually a confusing scenario most of the time in our clinical practice. So we have CCDs, we have other cross-reactive antigens. And now we are doing more and more of CRD. So the problem is we get too much of information. So we have to interpret the result of CRD very cautiously. So today to talk on that, we have Dr. Vikram. So he's from Navi Mumbai. I know that he's a very familiar face to all. He's a great pediatric allergist. And I would like to say he's a seasoned expert in the field of component resolved diagnostics, a good speaker, and more than that, a good person. So we would listen to Dr. Vikram how to solve the polysensitization puzzle by CRD. So over to you, Dr. Vikram.
Thank you, Dr. Hima, for the kind words for me. And thank you, Dr. Neeraj Gupta, for giving me opportunity to talk on this topic. So basically, when our purpose of doing allergy practice is to make the patient desensitize. And then Dr. Kashyapi has mentioned how we should approach a patient who comes with positive test on SPT and specific IG. But and she mentioned about various specificity, positive predictive value, negative predictive value of each test. But there will be, in our practice, there will be situations where when you are doing skin prick test, you will get many of the allergens coming as positive. So those we call it as polysensitization. Now, then you are confused whether we should go for immunotherapy to all of these or we should go for individual or the main one. Definitely from the history, we are going to, we will reach to a conclusion, but not always. Many a times, the history will not be suggestive. And there comes the role of component resolved diagnosis. So let us go through it. So, but before that, I would like to say this is a newer test and very attractive test, but it's a double-edged sword. When you use it rightly, it will give diagnostic and therapeutic precision. But if we are not knowing it properly, there will be definitely increase in the confusion. And why? Because see, this is a kind of report we can get. You can see everything coming positive. And now we all practice pediatric allergy. Suppose a child comes with this report, we will be confused what to give and what not to give. So all legumes, all nuts, all milk, egg, fish, all these are positive. So we may wrongly ask the patient to stop everything, and which will compromise the nutritional status. But here we are going to talk not only about the avoidance, we are going to discuss today how CRD will help us in immunotherapy. So this is a statement from Indian College of Allergy ICAI guidelines, which cautions us that AIT results may reflect failure if done by an untrained person, unnecessary testing, and most importantly, wrong prescription of immunotherapy. So the success of allergen immunotherapy depends on personalized allergen selection and correct diagnosis. Then followed by proper dosing protocols, patient adherence, and long-term follow-up is needed for successful immunotherapy. But how to have this personalized allergen selection and correct diagnosis? So to make it clear, Yaki has incorporated molecular-based IG testing in the flow chart right from history till the avoidance and allergen immunotherapy. At stage B2, they have introduced molecular-based IgE testing. Now what we are testing is IgE, and we know IgE is formed in our body against various allergens. Now, but is it so simple? Let us understand the structure of allergen first. So when I talk about one allergen, an allergen will have, it's a protein source which may contain several allergens, and each one may possess a number of potential epitopes. So what are these epitopes? Epitopes are the areas of a protein that interact with the B and T cell receptors on lymphocytes. And out of these epitopes, few will be clinically relevant, but many may just be there and they just share the structural similarity with other allergen sources. However, specific IgE are produced on sensitization. So our body, when we are talking about IgE, it is made up of various IgE against all these epitopes. So thus the IgE which is there, which we measure, is polyclonal and will reflect that produced to different allergen as well as to different parts of an individual allergen. So let us clarify from this diagram. So when we talk about IgE, what is total IgE? Total IgE is, now we know various causes of increased IgE are there. We know in allergic conditions, IgE are formed against the allergens. But in our Indian scenario, we have so many parasitic infections. So we have IgE against parasites also. So but when you measure total IgE, that's why we say not to use total IgE routinely for diagnosing allergy condition. So here, when we are collectively measuring total IgE against allergen, that is what has come as Fediatop. Now, Fediatop is excluding other IgE. It is just calculating the allergens. Now, these allergens Fediotop will just tell that ki IgE are produced against some allergens, but we don't know. Now, if I say these are multiple allergens are there, out of this, one HDM IgE is there, and that is going to get detected by serum specific IgE, this HDM IgE. But now, in HDM also, we have different components like DRP1, DRP2, DRP10, DRP3. So, each component will have a separate IgE. So, IgE will be against DRP1, DRP2, DRP10, DRP23. So, when we are talking SDM IgE, it is made up of various components. To name only, I have mentioned 4. So, there are more than 29, 30 house dust mite allergens which have been found till date. And these are detected with the help of component resolved diagnosis. So, what is basically component resolved diagnosis? So, if we take the allergen source, when we extract it, that is the allergen extract which we use for skin prick test and serum specific IgE, but that extract will have the specific species-specific allergen component as well as some cross-reactive allergen component. Here, the component resolved diagnosis will help. So, conventionally, in skin prick test or when we are doing serum specific IgE against the extracts, they contain multiple proteins leading to possible false positive. Now imagine if a patient has got this or this IgE against the cross-reactive allergen component, still our skin prick test will come positive. And even if it is present, the species-specific allergen component is present, still skin prick test will come positive. So it cannot differentiate between genuine sensitization and cross-reactivity. And lack of standardization in extract composition. We all know in our country we don't have standardized allergen, and because of this we may overtreat or undertreat because of this imprecise diagnosis. So here comes CRD. What it does, it uses purified native or recombinant allergens to detect IgE to specific IgE components, whereas extracts are heterogeneous mixtures. They are less specific. Molecular that component, these are single purified protein component, so highly specific and allow precise identification of sensitizing proteins. So differentiate between true allergy and cross sensitization. There are various platforms, but what to use? We have singleplex and multiplex. When you should use singleplex? When you suspect specific allergen. Now from your skin prick test, you are sure that, and with SPT is showing your correlation with the history, say indoor perennial symptoms and house dust mites come positive. So you should directly go for singleplex only because these are cheaper. Multiplex, when you are not reaching to any conclusion, and or if on SPT you are getting polysensitization, then definitely we should go for multiplex. So clinical use of CRD, as I mentioned, genuine sensitizer versus cross-reactive you can detect. Then component sensitization patterns like monosensitization usually indicates single source allergy. Polysensitization, it indicates multiple genuine sources or pan-allergen sensitization. So I showed you the report first. So it can be multiple genuine sources or many times maybe pan-allergen sensitization. So it is important for predicting disease persistence and severity. So it is also helpful in quantitative interpretation and in clinical decision making, like identifying patients who would benefit from AIT. So even if SPT is coming positive, your serum specific IgE is coming positive, still your immunotherapy may not work. Where CRD will definitely help beforehand only whether your immunotherapy may work or no. So let us discuss about these major allergens and the pan allergens. So what are major allergens? These are sensitizers more than 50% of a predisposed and exposed population. When it comes to pollens, it is more than 50%. A significant proportion of total specific serum IgE is directed to the allergen, that is more than 10%. For example, if serum specific IgE for dust mite terronicinus is 80, so DRP1, DRP2 more than 8, we call it as a major allergen. So removal of these allergens from the source material greatly reduces the biological and immunochemical activity of the extract. So if you remove these components and if you do skin prick test with the extract, it may come negative. So the allergen represents a significant proportion of the total extractable protein in the extract, and thus these major allergens, they are used as a marker of environmental exposure. And what are pan allergens? So pan allergens We have cross-reactive allergens, we know. So cross-reactive allergens means among phylogenetically related species, like we have the DERP1 and DERF1, that Farini and Pteronoceans, they belong to the same species. So there they will cross-react with each other. Whereas pan-allergens means cross-reactivity will be seen among phylogenetically dissimilar species. For example, the tropomycins in mites, snails, cockroaches, and shellfish, they share the same tropomycin. And when it comes to pollens and fruits, prophyllin they share. So that's why whenever there is respiratory sensitization to some pollen, they can give rise to oral allergy syndrome on consumption of those fruit or vegetables. So clinical utility, clinical decision making with CRD clarifies this ambiguous sensitization pattern, avoid unnecessary elimination, and assist in selecting patients for immunotherapy. Immunotherapy selection, it choose extracts based on dominant allergen components. So it will tell us whether the dominant or the major allergens are present or no. And they predict efficacy of AIT using CRD guided profiles. And then we have risk stratification with CRD. But today we will be discussing about the role of CRD for immunotherapy selection. For that, we need to know about the major allergens or the marker allergens of each allergen source. For example, when it comes to house dust mite allergy, major allergens are DERP1, DERP2, DERP23. They indicate true sensitization. Whereas DERP10, which is tropomycin, it indicates cross-reactivity. So thus, CRD helps tailor immunotherapy by selecting allergen extracts with major relevant components. So let us go through the case. Now, this is one patient, an adolescent. This is a patient who had come with skin prick test. You can see positive for DF, DP, and as well as Blomia, and cockroach was also positive on SPT. When we did serum specific IG, significant titers of the DF and DP are present, more than 100, whereas cockroach allergen specific IG is also elevated. Now, a clear-cut case, history is matching, we may attempt to start immunotherapy for this patient. Now, when I did component result diagnosis, see what it is coming. Now, DERP1, DERP2, they are coming as negative. DERP10 is more than 100. DERP23 is 0.03, which is negative. So, what it tells, whatever skin prick test was showing positivity was there on skin prick test and serospecific IG was all because of this DERP10 component. And we know this DERP10 component is cross-reactive protein. That's why cockroach is also positive. As we discussed, tropomycin, they cross-reacts with various cockroaches, crustaceans, right? So in such cases, immunotherapy will not work in such patients. So here CRD helped us. Otherwise, we would have started, and after 1 year or 2 years, the patient would have come without any response. So these are the tropomycin groups. These are various. The tropomycin in the dust mites is DERP10. Then tropomycin is the major allergen in the shrimp, that is pen A1. In cockroach, it is BLAG7. Again, in ascariasis also. Now, in our country, ascariasis is very common, right? Now, let us move to another case. Now, here you can see the skin prick test is showing 6, 4, and 5. Not very, not very, what you say, the large wheel size as compared to the other case. But when we went for the component result diagnosis for the same patient, here you can see DERP1, DERP2, and DERP23. All these are high, whereas DERP10 is negative. So this is an ideal candidate with clinical correlation. This is an ideal candidate for starting immunotherapy. And remember, we will send only component whenever our skin prick test is matching with our clinical profile. Never we should send for every patient. Now, this is a simple flow chart. We can go for stepwise. We are going for skin prick test. Skin prick test, what we do with Blomia, DF, DP. Now, say if all our Blomia is negative, DF, DP is positive, then straight away we will start with sublingual immunotherapy, DF, DP. Whether to start SLIT or SCIT, that is a point which Dr. Gayatri is going to discuss in our next talk. But, sorry. Yeah. But Blomia has come positive on skin prick test. DFDP is negative. Here also we will directly start with immunotherapy for Blomia. Here there is no confusion at all. Now, why Blomia negative, DFDP positive? I'm not going for skin prick test, because if it would have been DERP 10, Blomia would have also come positive. Now, here is the confusion. When everything comes positive, then what you should do? Then we have component result diagnosis, DERP 1, DERP 2, DERP 23, DERP 10, and then BLOT 5, which is the major allergen of the Blomia. But unfortunately, Blomia major allergen is not available in multiplex as well. It is available in multiplex, but not in singleplex. Now, if all these are positive, then you can see BLOT 5 is also positive, DERP 1, DERP 2 is positive. Then you will definitely start immunotherapy, because all major allergens are present. The patient will benefit from immunotherapy for DERP, DERP as well as Blomia. But if Blomia is positive, whereas DERP 1, DERP 2 are negative, then immunotherapy will be done with only Blomia. The next is only DERP 10 Blomia has come positive. Then you should think of cross sensitization and explore element ascariasis sensitization, and maybe sensitization through other shrimp and other things. Now, this was about the dust mites, which is very common in our day-to-day practice. Now, let's move to the pollen allergies, which is more complicated. Now, till now, from the history, as Dr. Kashyap mentioned, history correlates. Now, for pollens, when it comes to pollens, we need to know the flowering or the pollination season. And we used to narrow down our immunotherapy to the pollens according to the season, right? And as well as the geography. So there are various pollen calendar. This is one of the pollen calendar from Maharashtra. So this was the usual or traditional practice. But now what is the problem here? Now you can see many weeds, many grasses, many trees, they have pollination in the same season. So here comes again the confusion. Now, different pollination syndrome, pollination season, right from the history, seasonal allergic rhinitis, seasonal cases, you can narrow it down. But if it is the same, then the problem begins. Then comes the role of CRD. Now, before that, what are the pollen allergen protein groups which are there? Now, there are pollen groups, cell wall modifying allergens are there. Then we have allergens which are involved in defense, like PR, that is pathogenesis related protein, PR10, which is most commonly we used. Then we have PR10 like allergens. This is basically the major burst pollen allergen, BETV1, represents the archetype of all PR10 like allergen. And it is the main primary sensitizer in birch pollen endemic regions. So in our country, Himalayan belt, we have birch tree, and there elder tree, there we have this sensitization to BETV1. PR10 proteins defend plants against fungi and other microorganisms. So these proteins are basically protective or with some function for the plant. But when we are exposed, we get sensitized. So their homologs are also present in large number of plant-derived foods. So various raw fruits like nuts, vegetables, legumes, they will also have PR10. Like in the example given, the peanut will have PR10. So they will lead to oral allergy syndrome or sometimes even severe reactions. So these are few examples where PR10 allergens are present. The sensitizer is the birch pollen or the elder pollen or the hazelnut. But apple, carrot, celery, peach, soybean, hazelnut, peanut, kiwi. So if a patient comes to you with reaction to all these things, and even if your skin prick test is coming positive, so this may be just a cross-reactive component with the birch pollen. Then you take out from the history whether the patient belongs to the Himalayan belt or has stayed there. Then we have non-specific lipid transfer proteins. So these are minor allergens in pollens, but also present in seeds, latex, fruits, and vegetables. But remember, as we mentioned, minor allergen in pollens, but when it comes to mugwort pollen, that is Artemisia, it is the LTP is the major allergen. Then we have profilins and polcalcins. These are minor pan-allergens. They are involved in oral allergy syndrome or food cross-activity syndrome. Now, let us discuss briefly about the NSLTP, most frequent type of food allergies in adults and adolescents. What does it mean? So, when it comes to food allergy, we know that food allergies are more common in children, but we do get patients who are adults or adolescents, they also may come with food allergies. Then, definitely from the clinical history only, you should start thinking that patient may be sensitized to the LTP. So severity of the reactions seems to be higher in monosensitized LTP. Now LTP is a heat stable protein. So even on cooking also they can patient can have severe reactions. But if sensitization is only to LTP, the LTP is one of the panallergen. So symptoms are higher. But if sensitization is to other panallergens like propylene PR10, then the severity is milder. Now, true P3, that is the peach. Peach is the major allergen source for this true P3 and it plays a precursor role in the sensitization to other NSLTP. So that means first patient got exposed to the peach and that's why LTP syndrome. But when they are major allergen, the pollen form is the true sensitizer. For example, so in our country, very few patient must be eating peach or must have been exposed to some peach product, but many are exposed to mugwort, that is artemisia. So in such condition, even artemisia may become the true sensitizer. So most severe reactions are frequently associated with different cofactors. So isolatedly, they may not cause any symptoms, but if taken with NSAIDs or if exposed in presence of NSAIDs or exercise or any other stress factor, reactions may be severe. So these are certain LTP. You can see these are the fruit sources and these are pollen sources like mugwort, Olea europaea, olive, and lipid transfer proteins, Artemis V3, that is mugwort, True P3 pichur, Ambrosia A6 ragweed, and Parjay 2 pellitory. Now coming to pole calcins can be considered as markers of polysensitization, and pole calcins are again from the panelization. So what should be our algorithmic approach when we deal with pollens? So on skin prick test, if there is polysensitization to pollen, then check for specific IG to major allergens like BETV1, OLI1, artemisinin, RB1, and or whether their serum specific IG is panallergen. So if you come across a report of say multiplex report, you will try to find out whether propylene or polcalcin of some of the other pollen is present or no. If polcalcin is positive and main specific IG is negative, then you should not go for AIT. But if panallergens are negative and specific IG, these marker allergens are positive, then you should consider AIT to that relevant pollen. Profilins. Now, these are 5 to 50% of pollen allergic patients are sensitized to profilin. So, many times when you go through various pollens, many times multiple pollen allergens come positive on skin prick test, and that is profilins are one of the reason. Up to 50% of sensitized patients may have oral allergy syndrome in most cases. Now, clinical reactivity to raw tomato. If a patient comes to you with saying that raw tomato, eating raw tomato, watermelon, banana, or citrus fruits, they have some oral allergy symptoms, then you should always think of profilin hypersensitivity. So when it comes to tree allergens, now Betulice, as I mentioned, these are highlighted. This family of trees, they are present in our country. Betulice is the, as I mentioned, in the Himalayan belt. The Fabaceae, that is acacia. Acacia is the babul tree. Then Prosopis mesquite, what we call. These are commonly found in our country. Oleaceae group also, Olea, Fraxinus, Ligustrum. These are few from our country. Then tree pollen allergen PR10 molecule from the BETV1 is the major allergen, and from the Oleaceae group, it is the OLE1 sensitization is the marker allergen. Now, Betula, this is the birch tree, which in Sanskrit we call it as Bhojpatra. Now, BETV1 is the PR10. These are the marker allergen. If this is positive, this is the true sensitization, whereas profilin, polcalcin, all these are cross-reactive proteins. Now, when it comes to tropical countries like our country, we have Fabaceae family like Prosopis juliflora and Acacia group. So there we have this OLE1, the OLE1 like protein family member. So here you can see down we have this OLE1 protein family member which cross reacts with each other. Now, London plane tree also, if you come across some few of the multiplex reports, then PLA A1 and PLA A3, these are reported. And this plane tree PLA A3 belongs to the family of NSLTP, showing 58% with the structural similarity with the PRU-P3 from the peach. Now, let us discuss a case of 14-year-old girl. History suggests she was seasonal allergic rhinitis and asthma. Additionally, she has history of urticarial rash after some food items. SPT showed polysensitization, pollens, and food items. So this was the report, gross report. So you can see tree pollens are there, wheat pollen is there, legumes, grains, spices, fruits are also there. So will you start immunotherapy against pollens here? So let us break the report. Here you can see London plane tree is present, PLA 3 is present, and Artemisia V3 is present. Will you start Artemisia immunotherapy for this patient? No. As we mentioned, RTV1 is the major allergen from the mugwort, and when it comes to the food items, you can see maize, NSLTV from the fruit or the food item source, their main source. So in this patient, even if skin prick test is positive for the Artemisia or the Parthenium, because the group will discuss, so you will not start immunotherapy for this patient. Now, diagnosis for suspected tree pollen. If it is monoreactivity to the specific IG, then AIT should be considered. Polyreactivity to all extracts. If propylene, polcalcin are present, no AIT. If genuine sensitization, yes, you should go for AIT. Many a times you may get specific IgE to different pollens, a tree pollen or a weed pollen. You should go for AIT in both these conditions. Now coming to grass pollen allergens, unfortunately we don't get Timothy grass over here. This is from the temperate zone, but in our tropical country, cynodon is the major allergen, and CynD1 and CynD4 are tested. Now for a diagnostic algorithm for grass pollen, if PHLP1 is there, then you should go for AIT. If PHLP1 is negative, if other major allergens, these are the other major allergens from Timothy, then also you should start grass pollen AIT. But if these are negative, then no AIT, despite your SPT and IgE showed positivity. Clear? So wheat pollens, common weeds what we get in our country, ragweed, that is the ambrosia, mugwort, that is Artemisia, Russian thistle, and English plantain, they are not commonly present in our country. The biogeographical range and pollination periods of allergic weeds can overlap, confounding accurate allergy diagnosis. So as I mentioned, the Parthenium, the Artemisia, Amaranthus, they all pollinate in the same season. So how will you come to the conclusion? Now, for example, you can see this is Amaranthaceae group, right? So Amaranthus species we do test in our skin prick test. Now they are basically source of OLE1 like proteins. Now this OLE1 like proteins, if your Russian thistle come positive and Chenopodium album, these are also positive on SPT. So you can see these are cross-reactive with each other. Now OLE1, they cross-react 87% of FRA-E1, and then Salk, that is the Russian thistle, if it is coming positive, it is mainly because of the maybe Amaranthus OLE1 like proteins. Now, when we don't have these components, but if we do Acacia and Prosopis zulifera, if we don't have these components, and if our Russian thistle is showing positive, you should think that Russian thistle coming positive is because of the cross reactivity, because of this Prosopis or the Acacia group. So on SPT and the clinical history, we should correlate. When it comes to Asteraceae group, now you can see the Ambrosia, the Artemisia, the Parthenium, which is commonly found in our common sensitizer or common weed allergen, which is present throughout our country. Now you can see the flowering season, July to September, July to September, July to September. How from the history we will come to the conclusion. Here comes the role of CRD. Now you look for which component is present, whether it is lipid transfer proteins or pectin liase. Now from here you can see when it comes to ragweed, Ambrosia A1, if it is positive, then you should go for immunotherapy to Ambrosia, because here that cross reactivity is Artemisia V6. That's why this pectin liase is a minor allergen in Artemisia. So here you will not start immunotherapy with Artemisia, you will start with Ambrosia. But whereas if Artemisia V1 is present and Ambrosia A4 is present and Parthenium H1 is present, then you should not start for Ambrosia, you should go for only Artemisia. So you can avoid polytherapy, polyimmunotherapy, which brings down the efficacy. And when it comes to lipid transfer proteins, Artemisia V3, Pru-P3, and Ambrosia A6, these are LTP cross-reactive allergens. Then we have urticaceae group. Now, Holoptelia is also commonly found, but Holoptelia component resolved is not present. But if you are getting this pellitory, that is the PAR J2 or PAR J1, if they are positive, then you should start immunotherapy for Holoptelia. Then Ricinus communis, they have cross-reactive species for Olea europea. So if you are getting Ricinus communis as well as Olea U1 is present, so you can understand this Ricinus communis coming positive is because of this Olea E1 group which is present in the weeds. So as I mentioned, specific Ig to Ambrosia A1 is a useful marker for red weed sensitization. Artemisia V1 is a marker for mugwort sensitization. Artemisia V3 reactivity is for LTB sensitization. So this is a flowchart or algorithm for weed. Now this clinical algorithm incorporating CRD, take complete history first, perform SPT and IgE accordingly as in correlation with the history. If polysensitized patients or if the situation is unclear, then go for CRD. So on the basis of CRD, you stratify the risk and plan AIT accordingly, elimination and then challenges. So this, to summarize, these are the primary sensitizers from these pollens and the different allergen sources, and these are the cross-reactive. So if you come across some multiplex, if you may come positive for all these, you should select the primary sensitizers. So take home message, CID improves diagnostic precision, avoids overdiagnosis and overtreatment, enables personalized therapy with precision, must be interpreted by trained allergists, and should not become one more panel test in allergy practice. Thank you.
Thank you, Dr. Vikram. I think you have described in detail and you have clearly solved the puzzle of polysensitization. So for beginners, they may find it a little bit difficult, but you have clearly mentioned the concept of pan-allergen, the major allergen, the cross-reactive components. So thank you, Dr. Vikram, once again. So next, we will move to the next talk, that is picking SLIT or SCIT. And we have none other than our own Gayatri Madam, a great teacher. And I have learned the basics of immunotherapy from Madam only. And I would say regarding SLIT, so many of us are familiar, but regarding SCIT, the subcutaneous immunotherapy, only a few persons in India even can talk more authoritatively. And she is the one among that, and a person with great experience and proficiency. And more than that, she is multi-talented, a pleasant person, and gives a lot of positive vibes those who surround her. So I would like to welcome Dr. Gayatri. Over to you, ma'am.
Thank you. Thank you, Dr. Hima. It was such a nice introduction. Yeah, my slides visible? Is my slides visible?
Yes, ma'am. Your slides are visible. Please
Yeah.
continue.
Yeah. So I have in the next probably 20-25 minutes, I will have to speak. You have to excuse me, my voice is not great today. I will give you probably a kind of a comparison between the SCIT and SLIT, and then give you an idea where to choose SCIT and SLIT. So I might be slightly going through the little basics of the SCIT and SLIT through. We know that immunotherapy is not something new, and immunotherapy has been there since 1911. And the first modality of the treatment that was there in the which came in the immunotherapy was a SCIT. And it was probably later, much later, that it was only in the 1980s that the double-blind placebo control trials on the SLIT started coming up. And then eventually some studies on an intralymphatic immunotherapy. I think in the later part of the immunotherapy sessions, you have Dr. Neeraj speaking on to some newer modalities as epicutaneous and the intralymphatic immunotherapy too. But in the world scenario, probably in the last 1 decade, the world is moving more towards the SLIT. So since that the first position paper that we have from the World Allergy Organization, there's several refining on the sublingual immunotherapy, several more information on the sublingual immunotherapy that we are getting year by year. A slight difference in the mechanism of the sublingual immunotherapy from the subcutaneous immunotherapy is the oral cavity is the natural tolerogenic environment. Where does the changes occur here when you take the sublingual drops is the Langerhans and the monocytes, which are local lymphatic tissues, which are there in your Waldeyer's ring or in your sublingual area. So these are the areas which actually take a part in that development of those tolerogenicity. And one other very good thing also is that the retention of allergen in the sublingual mucosa is seen for several hours, and sometimes in some studies it is seen that it has been there for more than 24 hours also. Most of the studies that we have for the sublingual immunotherapy are done on single allergens. And there are studies which are done on the safety of multi-allergens and was found to be safe as a single allergen immunotherapy, because some of these things that we need to be aware when we choose the allergens for immunotherapy and which modality of allergen immunotherapy that I'm going to choose for. A little briefing on the subcutaneous immunotherapy. In subcutaneous immunotherapy, it always goes as an build-up phase and the maintenance phase. In build-up phase, we usually have a dilutions vials of usually 3 or 4. And during this build-up phase, the injections are given twice in a week. And that build-up phase till from that vial number 1 to 3 usually takes a period of around 4 to 5 months time. And the maintenance phase, which you start after around 6 months time. And once you reach a maintenance dose, the injections are spaced between once in 15 days to once in a month. That means that till that 6 months time, patient needs to have a very frequent visit to the clinic. And then his injection becomes once in a month in a conventional scheme of a subcutaneous immunotherapy. So what I spoke is the most commonly practiced way of a subcutaneous immunotherapy, which is called as a conventional schedule. But there are also cluster schedules, there are rush schedules, there are hypoallergenic extracts also, which gives you a shorter schedules of a build-up phase. Now, this cluster schedule and the rush schedules are basically to reduce your that initial build-up phase, which would usually take a 4 to 5 months time. So you are shortening that by couple of weeks in the cluster immunotherapy, and you are shortening it by 2 or 3 days in rush immunotherapy. So the differences are the build-up phase here usually takes 4 to 6 months. In cluster immunotherapy, the build-up phase is quite shorter. It takes around 2 months time. In rush immunotherapy, it is quite faster in 1 or 2 days time. So here you give injections, 1 to 2 injections per week. In a cluster immunotherapy, you give 3 to 4 injections per sitting. And then you have multiple visits in a week, like 3 or 4 visits in a week, and every time you build up a 3-4 injections. And in rush immunotherapy, it is under admission, and you do it in a 2 or 3 days time. Conventional immunotherapy is something that we can practice at a clinical based setting also, but also provided that the setup has a adequate facility to manage anaphylaxis. But the cluster immunotherapy and the rush immunotherapy has to be in attachment with the emergency room or the emergency facility too. while practicing a conventional subcutaneous immunotherapy, you don't require any pre-medication, but with a cluster and rush immunotherapy, you do a pre-medication. The advantage with the conventional pattern is that it is something that it is widely used, and when practiced properly, it is safe and it is well accepted too. Cluster immunotherapy, yes, you are building it up here faster, but the chances of systemic reactions are there here. The advantages are the rapid desensitization in both the these modalities. The disadvantage with the conventional is, yes, it takes a longer time. But the disadvantage with the cluster and the rush immunotherapy is there is a very high risk of systemic reactions. Now, there is also there used to be, or I would tell that there is used to be a product called as an acaroid, which is an hypoallergenic product of an house dust mite subcutaneous preparations. So hypoallergenic here means their allergenicity is reduced where their immunogenicity of the product is retained. So with which you are able to achieve a higher dose of the injections in a shorter period of a time, because the tolerability for the product will be very high because it is less allergenic. So here the product would come with only two vial number A and vial number B. So you would give a weekly injections for 4 weeks, and then you shift to a vial number B, which is your maintenance dose. So after 4 injections of a vial number B, you are almost in a maintenance dose. So that means that within 2 months, you would be in your maintenance dose, and the maintenance dose here was once in 8 weeks. So you would give injections once in 2 months' time. Similarly, the different regimes are followed also for sublingual immunotherapy. You will find the prescriptions where the prescriptions are once a daily. There are prescriptions which are given only pre-seasonal. There are prescriptions which are on an alternate week, or the once in 3 days. So there are different regimes which are followed even in sublingual immunotherapy. And again, in sublingual immunotherapy, the drop formulations are there and also the tablet formulations. But in contrast to SCIT, which we mentioned, where it's almost a mandatory that we always follow a build-up phase and a maintenance phase, the accelerated induction schedules with the SLIT do not appear to have associated with a greater risk of any systemic reaction. So rush, ultra rush, or a no induction SLIT, like where you don't do any build-up phase and directly want to deliver whatever the effective dose that you would want to give, is also quite practiced. In fact, worldwide, most of the standardized allergen product for the SLIT preparations follows no induction phase. So they will be directly starting with whatever the effective dose that you are wanting to achieve. Now, with this background knowledge, I would want to take further into comparison between the SLIT and the SCIT. So when we are comparing between the SLIT and the SCIT, we have to compare the efficacy. We have to understand where the adherence is better. We have to understand where the long-term effect is better. The safety is better in which form. The convenience is better in which form. And all these things matter while choosing whether it is a SLIT or SCIT. Okay. Coming to the efficacy, now you don't have an head-to-head comparisons between the SLIT and SCIT, but what we have is separately the SLIT with the placebo and the separately with the SCIT with the placebos, and we have the compiled data on that, and this suggests that the SCIT is found to be having a greater efficacy when compared to a SLIT. Many SLIT doses in these studies were also less than the daily dose and also had a varied regimen. That's one problem with the most of the SCIT have kind of a fixed maintenance dose, or this much of a microgram delivery in a month time. But whereas since we don't have a dose response curve for the SLIT, the studies that were included for these meta-analysis had the varied kind of a patterns of a representation among the SLIT itself. So probably if you isolate the studies which uses a high dose of a SLIT and has a uniform kind of a dosage, we will be able to get a better scientific outcome. The studies again have revealed that the 3-year adherence with a SCIT was found to be 23%, but the adherence with a SLIT was found to be only 7%. Now, any chronic disease, the adherence is a big problem. Forget about the chronic disease. Even in the 5-day course of an antibiotic, most of us don't finish it. So definitely it is a challenge for us to keep our patients on sublingual immunotherapy or a subcutaneous immunotherapy for 3 years' time. So we are at a point that we are challenged. The challenge in immunotherapy for most of the practitioners are that we don't have any doubt on the science of immunotherapy now. We have a good level of an evidence, but the problem or the challenge still that we all face is the adherence to the treatment. Why is that the SLIT has only 7%, the adherence at the end of 3 years? Probably it is also to do with the SLIT were found to have a lesser number of follow-up visits to the clinic. And very interestingly, it was found in some other studies that the dropout rate over 2 years for a children's scheduled return visits quarterly was 18.5 compared to 32.3% for those who were seen twice yearly. Compared to people who were seen only once a year, the dropout rates were very, very high, around 70.4. That means that the main reason that probably why you are having a lot of dropouts in this SLIT is it is a home administered and you don't have a close monitoring. You don't have a close monitoring here. And that's one of the reasons why it was found that the dropout rate were high. And that also gives us a clue that probably if we keep the follow-up visits as quarterly, that is 3 times in a year, which is quite doable for the patient also, where you can monitor the schedule, you can refine on the pharmacotherapy, assess on the level of the control and the comorbidities, and also you can proactively keep reinforcing them on the preventive care and the environmental control measures too, which will help in improving the adherence of the patient. But overall, if you see the adherence between the SCIT and the SLIT, the SCIT appears to have better adherence because of the frequent monitoring. So what's the long-term efficacy that we have? So right now, for the SLIT, it has been shown that the symptoms have been continued to be under control even after 2 years after the discontinuation. But we have a better studies in the SCIT at present where the reduced odds ratio even in the physician diagnosed asthma to 2 to 3-fold, even up to 10 years post immunotherapy to probably immunotherapy, sublingual immunotherapy also came much later in the market. So in future years, I hope that we would have a better long-term efficacy studies on SLIT 2. This is an important part now. For a sublingual immunotherapy, there were no serious adverse events that were noted, and most of the adverse events were only local, pertaining to the throat irritation, little bit of lingual edema or the buccal mucosal edema and feeling itchy near the ear. So all these were the things which were noted in most of the patients during the first few doses. Though that there are reported systemic adverse events too, but they are very, very rare, and they were found to be 1.4 in 100,000 SLIT doses. And none of these required adrenaline in the studies which I have mentioned previously. When it comes to local reactions of the SCIT, the local reactions are very, very common, and they are ranging from 0.7 to 4%. I would say that it is even more. The local reactions are quite often, we almost see with the every injections. But the large local reactions are also not a predictor of the systemic reactions too. The systemic reactions could be only in 0.2% of your injections. And the chances of systemic reactions would be high when you are administering the dose without monitoring the baseline disease, especially when asthma is there and FEV1 is less than 70%. So poorly controlled asthma or most of the systemic reactions were also found because of the dosing errors or the dosing from the new vial. The new vial will be little more be potent always. So it is a practice for some of the physicians. In fact, I would practice it when I open the new vial. I would slightly reduce the dosage for 1 or 2 injections and then updose it again during active pollination time and the concurrent use of beta blockers. So these were found to be the most common reasons to encounter systemic reactions. And SCIT should be practiced by a doctor who is well trained, sufficiently trained to practice SCIT and also to handle anaphylaxis. And he should practice in a setup also that which facilitates him to, practice the subcutaneous immunotherapy. Now, let me put a little bit a short note on the dosage that we need to use as a comparison between the SCIT and the SLIT. Compared to SCIT, the SLIT requires a much more higher amount of an antigens to achieve the clinical efficacy as quoted by the many of the studies. But as I mentioned earlier, we don't have a specific dose response curve. So it can act from 2 times to the 300 times also. But it is found that from many of the studies, we need to practice SLIT in a much higher dose than from whatever that we are putting an effective dose in the SCIT. So some of the studies concludes that almost the daily dose of a SLIT has to be equivalent to the monthly dose of the SCIT. That means almost 30 times the higher the SCIT dose is what is expected to be given in the SLIT to have a same equal efficacy of the subcutaneous immunotherapy. So this is the optimal dose of a SLIT that I have taken out from the standardized allergens. And you can see that almost all of the regime that I'm mentioning here is a daily dosage, and these are from the standardized allergens. So in a subcutaneous immunotherapy, say for example, in the grass immunotherapy, you would be giving 25 micrograms per month, whereas here you will be giving a 25 micrograms almost every day. Some decisions might also depend on the guidelines, what our guidelines tell. So say, for example, in the GINA guidelines, it mentions on an HDM tablet rather than the subcutaneous immunotherapy. So some may be more comfortable to either or stick to the whatever the guideline tells and choose only that modality of the immunotherapy to be on the safer side too. So the scenario at present in an Indian, I would want to tell to the Indian context also. For a subcutaneous immunotherapy, at present, we have Indian manufacturers who are preparing the subcutaneous immunotherapy only now, the non-standardized ones. The acaroids, which was present earlier, the standardized allergens, the hypoallergenic allergens, are not yet available, and they are presently out of Indian market. The SLIT, the drop formulations are there from the Indian manufacturers, and also the SLIT HDM mix tablets are available for us now, which is a standardized allergens, which covers the DARF1, DARF2, DARP1 and DARP2. It does not have the significant amount of a mlomia in it. Now, with this background knowledge, let us move to some case scenarios, and then let us see that how we take a judgment of choosing what would be better, or if I have to do SCIT, what I have to do, if I have to SLIT, what I could do. So he's a 13-year-old boy, case of allergic rhinitis, HDM sensitized, had taken a SLIT drops for 1.5 years earlier. Symptoms were partially better. They were not totally happy though. So had dropped the SLIT drops many a times in between while on course. So he was taking, even when he was on a course, he had many, missed doses or the discontinuities in between. Now the symptoms have been progressing after he has stopped, and the patient wants to restart immunotherapy. Now we need to restart immunotherapy, but we also need to understand on certain factors now whether what modality of the immunotherapy that I would be wanting to take. So my workup for this patient would be To start with, again, the regularizing the pharmacotherapy, environmental control measures, because many a times their perception on that the disease is partially, they don't, they feel that their disease is not totally under control, is they expect that once you start immunotherapy, all their pharmacotherapy should be off and they would stop it by themselves. So I need to give them a little bit of a realistic expectations, and I will have to tell them that I will have to let go the pharmacotherapy also, quite hand in hand. And probably I'll be in a good position to reduce pharmacotherapy. I may not totally promise them to stop pharmacotherapy for definitely for a while. I would want to understand the reasons for non-adherence. We also need to be, we always think doctor-centric decisions. Okay, so many a times we take a decisions on what we feel or what we have read, what the studies have told, but sometimes we also need to understand or make a decisions the patient-centric. So I would want to understand the reasons for non-adherence. Was it that he was getting better and he was living, or was it his negligence, or was he forgetting to take it, or what was the reason for his non-adherence is that I would want to understand. So if this patient is ready to come for the initial 4 months as a twice a week injections, then I would offer a SCIT as one option to this patient, because later it becomes only once in a month. And as we have understood that the adherence is usually better with a SCIT, and I would also be able to monitor on his pharmacotherapy also better with his frequent clinic visits. The other thing that probably I would also think of, if we deny SCIT and still he wants to stick on to the SLIT, is, yes, taking care of the adherence and all those issues, is that I would want to go a little on the higher dose of the SLIT and the frequent follow-ups. I will make it a point that his follow-up schedules are quite on time and make a shorter follow-up visits. And yes, of course, I will also think on what Dr. Vikram has just mentioned on the, the presence of the DERPI 10 or a DERPI 23. And because of that, whether he is not a good responder for immunotherapy too. So the case number 2 scenario is that we have a 12-year-old girl with a history of rhinitis, strong family history of asthma. The symptoms are perennial and more in morning hours. Skin prick allergy test has revealed the reactions of DF 8/8, DP 9/8. Blomia is 3/3 and cockroach is 8/8 with a good positive and negative control. And the parents are considering to put her into a boarding school next year. In fact, many patients who are in that 9th, 10th always, gives us a little, uncertain situations where the kids are going to study, they are going to stay in Bangalore, or they're going to move out. Such scenarios are quite often there. So there are some things that we need to consider in such scenarios. Is consider also the near future plan of the patient. So is the patient going to be there for your availability for the 3 years time? So probably for this patient, I may not have even if I start on the SCIT, I may not be able to continue the SCIT after 1 year if the child moves on to the boarding school. And also I need to understand that if I give a sublingual immunotherapy drops, which need to be maintained in a cold chain, that again might be a challenge if the child is in hostel or the boarding school. Now for this patient, since Blomia is not the major sensitizer in an SPT, SLIT tablet is something that I would consider as a good option, and I would give that option as a first option to this particular patient. The next scenario is where we have a 28-year-old female presents with a history of runny nose, sneezing, intense eye itching and predominantly this is patient from Bangalore, and intensely in the later monsoon season and the winter months since last 2 years. Patient is from Patna and feels better whenever she goes there for a vacation. And SPT has showed the following reactions. Now amaranthus 8/8, Chenopodium 6/6, Parthenium 7, Mugwort 7, Ricinus communis 9/12 with Pseudopodia and Erythema, Prosopis juliflora 10/12, Acacia also 10/10. with good positive and negative control. So now we have a polysensitized patient and probably also polyallergic, not just sensitized here, because she does have a pollens which are pollinating in the monsoon season, pollens which are in the winter season also. I'm sure in such kind of a scenario now, Dr. Vikram is thinking that the CRD would definitely come into help. Yes, I do agree. But if I have to just consider immunotherapy on an SPT basis, now Amaranthus chenopodium cross reacts here, so I could still keep one pollen from there. Parthenium mugwort again cross reacts, I could keep one pollen. The Ricinus does not cross react with anything. And Prosopis casei again cross reacts. Prosopis is a little more immunogenic, so I would probably, or more allergenic. So I would probably keep a Prosopis. Though there are a lot of KCR trees in Bangalore, I will still compromise on that. So even if I rule out the cross reactivity, I still have to consider 4 allergens. Now we have discussed that the SLIT is more and more effective when practiced with a less number of allergens. The lesser that you keep your allergen extract in the SLIT, the efficacy would be better. In fact, that applies to the whole concept of immunotherapy itself. But especially when it comes to SLIT, we still are not very clear whether mixing too many allergens would still give us the same result. So if I have to go study wise and the previous scientific evidence that we have, so for this patient, the SCIT may be a better option. Or if I have to consider SLIT, I will have to probably keep it as a 2 separate kits, 2 with the weeds and the 2 with the trees, something like that. So that the concentration of the allergen that I deliver in each of these kit will not get compromised as compared to what if I mix all the 4 allergens in one kit itself. The last, the case 4 is a 7-year-old boy with a history of frequent cough, more at night time, gets better with a nebulizer therapy and used to have a dry skin earlier. Occasionally has runny nose, which was, the history was given on asking, though that was not much bothering symptom for them. Now, the skin prick allergy test is sensitized to DF, DP, and Blomia. All are 7/7. All are almost an equal reaction with good positive and negative control. FOT showed the small airway obstruction with a good bronchodilator response in R5. Patient symptoms were initially stabilized with ICS-LABA, but whenever there are missed doses or whenever even patient has an exposure at home with dusting or such kind of an exposure, the patient symptoms really gets bad. So planning to start, if you are a person you are planning to start immunotherapy, the thought process that should start for you is, of course, it's quite a young boy, so I will need to look on the convenience aspect of this also. So which is more convenient for the patients, whether the sublingual immunotherapy or a subcutaneous. The SLIT tablet would be something which would be very easy to administer to, but in Indian context, at present, we have a SLIT tablet which is being approved for more than 12 years only. And though it does give some amount of the blot 8 coverage from the Blomia 2 because of the cross reactivity, it may not be able to cover the entire this thing on the Blomia. So if you have a significant Blomia sensitization along with the DF and DP, SLIT tablet may not be a good option. So here I would choose SLIT drops as the option to start a allergen immunotherapy. So to take home message, how to decide on the SLIT and the SCIT depends on several factors, starting from the efficacy, the adherence, the safety, the affordability of your patient, whether your patient is monosensitized or polysensitized, the type of the training that you have at present and the setup that you are practicing. And of course, the one point that I have not mentioned is also the approval factors, like, whether it's a DGCA approved. So most of the institution, since because of that sublingual drops, since don't have an approval, would prefer to practice only the subcutaneous immunotherapy. So ultimately, it is a combined decision between you and the patient. So it has to be both your centric and the patient centric. So thank you. So There I end my talk.
Thank you, Dr. Gayatri, for the clear message and the clinical scenarios. I think the message from today's talk is, so for a successful allergen immunotherapy, so we have to have a good clinical history and the clinical identification of the allergens, and we have to interpret the skin prick test as well as the specific IgE properly. And now we do have a component resolved diagnostics, but we need to have a good amount of knowledge to interpret the component resolved diagnostics. So I think now we would move to questions. So I would invite all the speakers. So the first question is from Dr. Jitartha Barua. So if both SPT and IgE specific to dust mite is negative, can the CRD to dust mite be positive? Is there a possibility like that?
Yeah, I think this question is for me.
Yeah, yes, Dr. Vikram, you can answer.
Yes. So now when it comes to SPT, yes, SPT may be negative, and you can pick something on CRD because when it comes to SPT, we need to have standardized allergens. We need to have proper storage conditions. If during transfer from the manufacturer to us, if the potency of the allergens may go down, and then skin prick test may come negative. But when it comes to specific IgE, it's an extract, a standardized extract. So the chances of having negative on serum specific IgE to extract and CRD coming positive is rare. And vice versa, if I say, now skin prick test coming positive, serum specific IgE coming positive, CRD may still be negative. Why so? Now I'll give you an example of, say, dust mites. We have Farinae, Terronicinus, and Blomia. So when it comes to a multiplex which are available commercially, now there are approximately 31 components for Terronicinus which are present, but we are testing only 9 out of them in the multiplex, and 2 components for the Farinae and 3 components for the Blomia. So it is quite possible that our skin prick test is showing positive, serum specific IgE positive. Maybe that component which is responsible for positivity in the skin prick test, so CRD may come negative in such conditions.
Okay.
Thank
you,
you,
Dr. Vikram.
So the next question is, if the wheel diameter during SPT or
Sorry.
so if the wheel diameter during SPT or the absolute value, is there any echo?
Yeah, I think you have logged in on two
Sorry.
devices. Yeah.
Just that. Sorry, my camera on the laptop was not working. That's why. Sorry for that. So if the wheel diameter during SPT or absolute value during immunocap is very high, so does that mean more chance of being allergic to the culprit allergen? And should we start lower doses in such patients, or can we start routine doses? So Dr. Gayatri, can you please take up that question?
Yeah. We have seen where the clinical symptoms were not very high, but where the SPT reactions were very big. On the other hand, also where the clinically they were like having a very, very symptoms, and the reactions are just like a 6 mm or just barely positive, 5 mm. So having a huge reactions would not really be my only judgment to start with an extra dilutions. If clinically it correlates to, then I would definitely start with an extra dilutions. And especially in sublingual immunotherapy, now that many of us have started with the high dose of the SLIT tablet, and we are seeing that they all tolerate it very well. I feel that we were very, very conservative in giving all the updosing with the sublingual immunotherapy. But yeah, so the only dimensions would not be my criteria to make an extra dilutions. No. Combining with clinical, yes.
Okay, thank you, madam. So another question is in vernal keratoconjunctivitis. So usually we know that it is not a purely IgE mediated disease. So many patients came with who have already started with refractory VKC on cyclosporin or tacrolimus. So if such patients are referred to us, so what will be our approach? Can we go ahead with the skin prick test, or should we go for other in vitro test? So what will be your opinion? And regarding immunotherapy, so some of the cases we get house dust mite positivity. So what will be the response of AIT to in case of VKC? So is SPT, shall we proceed with SPT or should we go ahead with an in vitro test?
See, most of these patients would have been referred to us by an ophthalmologist for one allergy evaluation too. So I would do definitely an allergy evaluation. As a part of that, I would not manage the eye. So I would still only look into the allergy component of it. And if the patient is, I usually see it for the dust mite and the ricinus communis quite often in Bangalore. So if it is a only conjunctivitis without any other respiratory allergies, I put a immunotherapy as a plus or minus. I won't promise too much, as much that I would give my counseling to the allergic rhinitis, or when I'm counseling it for asthma. But if it is combined with allergic rhinitis or with another respiratory conditions, or even has an atopic dermatitis, my promise will be more with immunotherapy. Otherwise, I just keep their expectations quite on in this thing as an add-on to whatever that you are doing. If you still want to try with this, you can try, is what I will tell. I would like to hear from other panelists too, what they have.
Dr. Vikram, Dr. Kashyap.
Yes, same here. Same here. When it comes to isolated conjunctival involvement, definitely I will also be restrictive. I will not give a hope to the patient.
Okay. Thank you. Thank you, Dr. Vikram. So the specific IgE can be false positive in certain cases. So is it possible to have a negative specific IgE and a positive skin prick test? Can the specific IgE can be negative and skin prick test is positive? Is that possible? Is that scenario possible?
Yes, it is. It is possible.
Yeah, thank you. Then suppose among the tests performed, a higher value is suggestive of more chances of being the culprit. Is it true? This is yet another question. That means those allergen having a higher value in any of the tests performed, can that be the main culprit? Is it true? Even if it is SPT, or if you get high specific IgE values.
I will
So
tell
does
you,
that mean so, especially in
the SPT, I will let Dr. Kashyapi and Vikram answer on the in vitro testing. In SPT, if something with a pseudopodia is there, definitely we kind of mark it, and we do consider that. More than the size, what I ask my patient is which is itchy. If some two reactions are similar, so or this and this, and so if I'm considering 4 or 5 allergens which are very important, I also ask them which among this is very itchy. Now the more itchy for me is more close to the clinical scenario. So that is what the same allergens will do when the allergen enters his nose. So rather than the size, I ask for which is more itchy in these patients. I mean, I always tell this. You also would have heard in the teaching, not in the textbook. It is from my clinical experience, and that has really worked well in choosing allergens too.
Thank you, Dr. Gayatri. Dr. Vikram, you would like to add anything onto it?
Yeah. So I'll add on over here. So it's mentioned, Dr. Gayatri mentioned itchiness, but in textbook, it is mentioned that the greater the wheel size, it has got a better correlation with the clinical history. And same is true for even serum specific IgE value. When it comes to CRD, again, when CRD components also, when you look for the values, again, clinical correlation is with higher values, except for the LTP. So LTP higher values will not correlate with the clinical scenario.
And with respect to what Dr. Vikram also said, it is said in a literature that more than 6 millimeter of an SPT reactions has a more clinical correlation, more than that when you have that.
Dr. Kashyap very well mentioned the studies also. The cutoffs for various allergens for the skin prick test wheel size to consider it to be a significant, clinically significant condition. Dr. Kashyap, your comments.
Yes, sir. So again, here is where we have a non-agreement with clinical experience and textbook teaching as well. So the cutoffs may not be very standardized to every patient which is there. So definitely, I will stick to the clinical history as. Dr. Gayatri ma'am has always mentioned. That's actually a very good point. Asking itching pattern about which area is actually more itchy. So that is something which I would consider. I'll not definitely go only by the values which are mentioned both in specific IgE or CRD for that matter. Clinical correlation is something which I'll definitely see, because in this era where the labs are leading the patients to the doctors, it's very easy to get misguided by looking at the report and just starting immunotherapy randomly. The patient ends up asking you, why are you not, and AI has complicated that more. So when we tend to probably suggest something to the patient, like this will work for you, they'll immediately probably check on AI and they'll be like, oh no, this doesn't work for you, why are you suggesting it to us? So definitely clinical correlation with experience is what I would give more importance to than anything else.
Thank you, Dr. Kashyapi. So next question is to Dr. Vikram. So what's your take on CRD in today's scenario in India? So what will be your recommendations for all four or few for AIT? And regarding the technique, so testing, the component testing, you prefer the immunocap versus the Alex. So what's your comments?
Good question. Now, as I mentioned in my slide also, so when I am sure from the clinical history and from the skin prick test, then I'll go for the immunocap singleplex, which has recently been launched in our country in, I think, last 6 months. So we are getting singleplex. What do you say, the value of singleplex is better. The immunocap method is better as compared to the LX. But when it comes to polysensitization, and if the clinical scenario is not matching with your skin prick test, there definitely multiplex will help. But again, the problem with the multiplex, like many pollens, when it comes to pollens, Indian pollens, Indian allergens are hardly covered.
Okay.
So many from India aspect has to be included in the multiplex.
Thank you, Dr. Vikram. And then in atopic dermatitis, you usually find it very difficult to perform a skin prick test, especially in severe atopic dermatitis. So what's your take on starting allergen immunotherapy based on component result diagnostics alone?
Here, interesting. Basically, atopic dermatitis is a genetic condition in 50% of cases. The filaggrin mutation is there. And as the skin is damaged, there will be transcutaneous exposure to various allergen. And if we perform skin prick test, or if we do component result diagnosis, many may come positive. And here is one condition where we have to be very cautious before interpreting, because in an atopic skin, they may be just sensitized and they may not be clinically positive. So in such condition, it is a tricky situation. There comes the role of oral food challenge. If we have strong correlation, if parents are saying that strong correlation is there, definitely. But here, if we go for skin prick test, again, many things may come positive. And I'll say these are false positive.
Thank you, Dr. Vikram. A child with atopic dermatitis had a strong history of worsening with egg and milk. Serum specific Ig for milk and egg were negative. And is a skin prick test indicated especially with a sensitive skin, or can we just eliminate the food and gradually reintroduce when the atopic dermatitis is under control? Dr. Kashyapi, you would like to take that question? So it's a child with atopic. Yeah, please.
So atopic dermatitis, as Sir just mentioned, the situation of polysensitivity is very high. I would definitely, consider a specific IgE over here, since they've already done it and then it's negative. I would see if the clinical correlation is very high. Like if the parent is saying that the symptoms are aggravating after introducing egg or milk, then probably I will ask them to stop it. But randomly, if it is not at all correlating, because it is multifactorial when it comes to atopic dermatitis. So that is the main reason where I would definitely try to correlate it clinically and then advise the patient. Again, ultimate test would be proving it by doing a challenge. But again, in this case, it's absolutely not necessary, because milk and egg, until unless the age indicates, milk and egg are something which we need not challenge the patient to at this point of time. So yes, I will consider both the negative values of SPT and specific IgE, but clinical history of what the parent gives is what holds the best weightage, according to me. Any comments, ma'am, Vikram sir?
I agree with you, completely agree.
Agree.
Thank you. So, Dr. Vikram, there is a question for you. If someone is sensitized to NSLTP, I think you have described it. So that means cross-reactivity to many allergens. So how will you approach that? So will you advise all the food which are cross-reacting, or will you advise AIT to mugwort pollen?
Right. If mugwort is is showing it as positive, then I will definitely consider this to be the primary sensitizer. Because for mugwort, LTP is the major allergen. So definitely I'll consider mugwort pollen immunotherapy. But if mugwort is negative and other food items are present, then definitely from the clinical history we have to go for. Again, LTP will be present in many various legumes, various lentils, and various nuts. So again, you make from we get such reports, and many times patient tells that they easily tolerate or they easily consume those things, and they don't get any reaction also. So here comes the history part, the importance of the history, and here we can go for oral food challenge.
Thank
Like
you.
in
Thank
the
you.
example I showed there, in that patient, the maize was the maize titers were more, and peach was also there. But clinically, the patient was tolerating peach, but maize the child was unable to take. So for here, I will not ask her to stop peach in this case.
Thank you. Thank you, Dr. Vikram. There is one question that is from Dr. Raj Shekhar. Are there allergy tests for mosquito sprays? I have not heard.
Mosquito spray.
Yes, ma'am.
So that is not an allergen at all. So that's more a irritant.
So
Dr. Hima,
I
are you
think
around?
there are no more questions in the chat box also. Dr. Neeraj?
So I would like to have few questions. Like for an example, many times we see moderate to severe atopic dermatitis patients, and these could be even a child or an adolescent, and presenting to us. And when we are testing them, then at that time, both the skin prick or specific IgE, suppose they are coming positive to dust mite, and the numbers are really huge. Means like you cannot ignore these numbers; they are really huge. And so, would you like to consider this patient for allergen immunotherapy for dust mite? Because they are actually getting moderate to severe problem and they are like wanting some respite. One scenario, if it is associated with respiratory allergies, could be asthma or rhinitis. Other scenario, only dermatitis, no associated respiratory allergy. So what will be your take?
So as I mentioned with the vernal caridvocacy earlier, with respiratory, definitely yes. Definitely a strong yes is what that I would tell. Now, only atopic dermatitis is also one of the indication which is slowly coming up, but again, we don't have a good level of an evidence there. So I would, because if the patient has tried everything and even with the maximum effort, if the patient has been still having an exacerbation, I would give them offer of an immunotherapy, but I will not be in a good position to, give a strong counseling to them. So I would tell that this is something that we can try along with all other things, and we will see that how it happens over a period of a 6 months to 9 months time. If it give you a response, we will continue, or otherwise at the end of a 1 year, we will review whether to continue or not, would be my, that's how my counseling would go.
My second question is as we discussed earlier, and I think you answered it, that for an example, if in a given patient, you are getting a specific value, that could specific value of either SPT or specific IgE, let's take two allergens are there. One allergen value is coming out to be 4 millimeter, another one is coming out to be 8 millimeter or 10 or 12. Similarly, for specific IgE, one value is coming as 10, another value is coming, let's say 80. So, and you decide that, okay, these both allergens are relevant and these both needed to be given immunotherapy, and you are going for a therapy. Now, my question earlier was, which you have already answered, that would you like to give, you can say like in a bigger reaction, that could be like a SPT bigger reaction or specific IgE bigger value. You would like to start with more diluted doses of the allergen immunotherapy, thinking that he might react more, or you would like to just start with the conventional regime, irrespective of the size of the wheel. If it is positive, matching with the clinical history, you are going to means like give the same value. So
I think we already, addressed that. I would usually start with a conventional dose itself, unless otherwise the clinically also, if the, unstable asthma or something like, such scenarios are that I would want to be little more careful. Otherwise, I would start with a conventional.
So I also do the same thing, but why I brought this question? So I will tell you, because there are two school of thoughts. There are few allergists in the country who are doing exactly the same thing. I am also doing the same thing, what you have told, that we, irrespective of the size, we are giving the same doses. There are other allergist group. What they are doing is that they are actually measuring the wheel size, and if the wheel size is more, then they are getting, you can say like more proportion of that particular allergen immunotherapy in the mixture vial, and the wheel size is less, then they are getting the lesser proportion of that particular allergen in that vial. So I just want to ask about these two practices. What is your take about that?
I got your question. So what I was mentioning was making an extra dilution. Okay, so like if I'm starting with, I'm speaking with respect to the Indian allergen, the product which we have. Like in most of the Indian allergen product will be 1:500, 1:250, and 1:50. So my decision on making an extra dilutions when I meant is starting with 1:1000. So I would usually not start with a 1:1000 just on the wheel size, unless the wheel is. I have had a patient where the wheel size is like a 30 millimeter, so that is like very huge. So I would be a little careful. But what you meant is like if there are two allergens and I'm mixing a two allergens, and if one is 8/8, one is 6/6, and the proportion of the allergens that I'm going to keep is whether it's going to be 50/50 or a 60/40.
Yeah.
Yes. The teaching that we have at present is a 60/40. So in that, when we are mixing, is a 60/40 is what we are keeping. I'm not meaning an extra dilution there. Okay, so as when you are considering two allergen and you are wanting to represent that, I would say that even keeping that in an equal proportion is also not wrong. If the clinically there are not too much of a variation, so it's fine. If there are not too much of a changes, it's still fine. But no extra dilution. Not starting with 1:1000 is what I meant. I did that.
Dr. Gayatri, here there is a little, I will say, like I would like to discuss with you. Why I am discussing? Because once again, two school of thought. So one school of thought you have told, the school of thought is that you have to just take the maintenance dose, as you mentioned about probably the pollen or probably the dust mite. And when you are taking that particular maintenance dose and you are calculating, you can say like when you are taking means like the maintenance dose and you're calculating for 10 months dose or so, and you come out to be okay. In this particular 1 ml solution, you need to get this much ml of this for a 10-month one, and rest of the things will come as a saline. Suppose if the second allergen needs to come, then the second allergen will also come as per its dose, and then rest of the things saline. So in this particular calculation, actually, we are not taking care of the wheel size. We are just taking care of the wheel size. If it is positive, we are considering, okay, it is sensitized, it is positive, and we are going forward. So that means allergen 1, allergen 2, allergen 3, whether something is 10 millimeters, something is 6 millimeters, something is 8 millimeter. We are not giving that value. We are just saying, okay, it is positive, it is clinically relevant, we have to give it, and then as per their maintenance doses, we are adding it up. What you're telling me is about the 60-40. So here now, each and every time, now the things change. So I hope I'm clear to you. So these are the two school of thoughts which are going on. So
Yeah.
I still don't have the answer to that. What is correct?
I get it what entirely that you are. If we have, see, most of the standardized allergens, if you see, they don't depend on their calculation entirely doesn't depend on your wheel and flare reactions at all.
Absolutely. Yeah.
Whether it is if your DP gives 10 millimeter, DF gives 5 millimeter, still you are going to give the same direct
Absolutely.
this thing. So even when I discussed the same thing with Dr. Vedantan earlier, so he did mention that in a non-standardized allergens, they do kind of calculate the dose depending on the wheel and flare reaction. So all these things usually comes that your calculation of this thing go to the non-standardized allergens only. When you know that the standardized allergens and this much microgram, okay, for a dust mite, I'm wanting to deliver a 20 microgram. It is you just calculate that how you are wanting to give the 20 micrograms. You are not even calculating any wheel and flare reactions there. These wheel and flare reactions and these percentage calculations, etc., usually comes with a non-standard when we are considering a non-standardized allergens where we still yet not sure that how much allergen that I'm going to deliver. So that is where you are not just keeping them in a fixed proportion or a 50-50 proportion and taking this.
Okay. Right. So I think we have got a very wonderful webinar today, and I think Dr. Kashyap started on a very strong note in which she spoke about skin prick test and simultaneously the specific IG. And the main message was that actually in the follow-up, the clinical score and the symptom score, which is mainly important, or the pharmacological score, which is more important rather than repeating any particular test value. But in a given patient, you might need to do it in certain situations. And then thereafter, Dr. Vikram, he just, you can say, like about the molecular diagnostics, he got a deep dive. But what I understood that we need to still, you can say, like have a much more better understanding, much more, you can say, like refined molecules, especially to our country. And then we might be able to, you can say, like give a very streamlined flow chart. But right now, whatever it is, I think the main message should be that skin prick test on the specific IG needs to be the main core. And if somebody who is stuck up, it is always better to, you can say, like get a good advice from people like Dr. Vikram, who is really an expert, at least in molecular diagnostic. He has done really wonderful work. So I think this is there. And then Dr. Gayatri is simple, means like awesome, amazing, as always. So allergy and immunotherapy, the second name is considered to be Dr. Gayatri Pandit in India, at least what I understand. So she is really amazing, and as so simple way she presents, teach, that I really enjoy each and every session of her. And so thank you all of you. And I think Dr. Hima has done really a wonderful job today of moderating a difficult webinar and difficult things. So thank you very much, every one of you. And tomorrow, once again, we will be coming back at 8 o'clock with the third episode, in which we'll be discussing further about that how this AIT works, that whatsoever protocols which we have discussed today, how we can implement that in the practice. So we will actually talking like moving out of the vials to the clinical side, to the bedside, and see that how the things are happening. We will also talking about safety and efficacy more. And then once again, we will be also talking about that whatsoever guidelines which have been discussed today. So how these guidelines can really be implemented in the practice, and what is actually important for you all, for us, when we are looking a patient, seeing a patient at the bedside. So till then, please stay tuned. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Sir.